Nick Majerison here, and it's time for a conference highlight. And this is taken from our coverage of Anaesthesia 2018, the international meeting of the Royal College of Anaesthetists. It features Desiree Chappell and Monty Mythen, with guest Dr. Liam Brennan, the president of the Royal College of Anaesthetists, and Professor Paul Myles, the director of the Department of Anaesthesia at Perioperative Medicine at Alfred Hospital and Monash University in Melbourne, Australia. In this fascinating clip, we hear how a global perspective actually enhances the discipline. Have a listen to this.
Top Bed Talk.
Dr. Brennan, when we interviewed you back at the ASA and you were talking about how we have outreach to other providers in other countries, what is the college doing for outreach and curriculum for those particular providers?
So outside of the UK, so we've now got a global partnership program that is in its infancy. We are doing a lot already. We're doing some work in developed world countries, in Hong Kong and in Iceland, to build that infrastructure in education, learning, and around perioperative medicine. But also in the developing world, in low and middle income countries, we're doing work in sub-Saharan Africa, particularly around East Africa, in Zambia in particular, where we are starting to build that to meet the vision of what perioperative medicine means for local needs. It will be different from the spectrum of disease that we see here in the UK and Australia and the US. It's not going to be around the obese population. It's not going to be around the consequences of alcohol and cigarette misuse. It is going to be around some more fundamental issues around infectious disease and how we manage those issues. So making it more fit for purpose and adaptable, I think, is the challenge.
So, Paul, on that subject, there's often a question, most of the world is not getting access to the type of healthcare we regard as relatively normal. Has this perioperative medicine agenda got anything to offer, the global challenge for access to healthcare? Because I know there have been some developments in relatively less well-resourced countries.
Well, I think it does really. I mean, some of the key principles of what good perioperative medicine would be, things like teamwork, things having shared understanding, things that avoiding gaps in care that might otherwise happen with a fragmented healthcare system. So those principles, I think, are universal, and they don't cost much money. It's really about just the way we work, the way we're trained. And if we do that in a fairly coherent way in all parts of the world, then in fact everybody, and certainly the patients we care for, will have better outcomes.
Do you think some of those countries might get well ahead of us in actually being able to, in them starting off their journey of the better provision of surgery care, jump ahead to what looks like a fully developed perioperative medicine model, because they won't have the sea anchor of our traditional care practices? Yes,
I think the word disruption was used today, which I think is a really good phrase, where we as specialists are often caught up in the old paradigms of care, the silos of care and so on. We have to break some of those down, retrain ourselves, and of course pass it on to the junior trainees who are coming now as specialists. In systems where they've got little such parochial specialties, who are actually really trying to do the bare minimum as best they can with few resources, already are working very well together to problem solve and come up with the best care they can as a team. So I think there's great opportunity there for them to actually get ahead much quicker.
So one of the points I made in my talk this morning was that the birth of the NHS gave parity of esteem for anaesthetists in this country. I think for many of the low and middle income countries, they are still at that point or even earlier, where there are very few physician anaesthesiologists, and we need to raise that. We need to raise the numbers of those practicing in those areas. But once they're there, and the ones already there, have got to be given the same esteem and regard as alongside their surgical colleagues. That's going to be essential to developing this team approach that we all think is essential to perioperative medicine.
Can you remind us about that, Liam? Because the history of that is very interesting, because we got right close to the wire, as I understand, in the formation of the NHS.
Sure.
And there was a potential for us being part of the surgery team, not an independent profession right at that moment?
Sure. So post-war, 1948, just after the Second World War, we had a socialist government came into power in this country, and their vision was that we would have a national health service free at the point of delivery, and I think it was visionary at that time that to be essential to that all doctors working within the service should have parity of esteem. And anaesthetists were raised overnight from being a second-class citizen, if you like, within the hospital infrastructure to being on a par with their surgical and their physicianly colleagues. And that was a quantum leap for the specialty in this country, and that was reflected in how we developed initially as a faculty of anaesthetists and then subsequently as a college and as a Royal College. And for that we are incredibly grateful in this 70th year.
How did that happen elsewhere? Do you know, Paul? Did it just you followed suit? I'm not suggesting that we were leading the way, but...
Yeah, well, I mean, that's a really interesting point, really. I think that sense, sort of more egalitarian sense that was embedded in the NHS from the start, I think certainly not just helped our specialty, but I think improved, I guess, respect for all the players involved in the care of a surgical patient. I guess it's one of the reasons why perioperative medicine has worked very well in the UK system. Australia's got a sort of a hybrid system. It also has the National Health Scheme, but a higher amount of private practice medicine within the country. And of course other parts of the world, particularly North America, it's even more so. So these features are there, but what I think was really right there at the start with the NHS was around public service, public good. The centre was healthcare for the population. That wasn't the case in traditional areas of medicine elsewhere. It was often doctor-focused and there was hierarchical systems. I think where we are now with perioperative medicine is, again, everyone's talking about patient-centred care, team-based care, but for some parts of the world that's been a harder change to move into than perhaps in the UK system.
Top Med Talk.
That conversation was taken from a longer piece called RCoA 4, the Royal College of Anaesthetists, World Leading Healthcare. Look for that title on topmedtalk.com. Do remember you can meet the Top Med Talk team when we're going to be at the results of the Extreme Everest Symposium, June the 14th, live from Duke University in America. And of course, we're at all of the EBPOM meetings. Check out ebpom.org and find out how you can meet the Top Med Talk team.